According to the South African Society of Psychiatrists, men are 5 times more likely to die from suicide than women. 190 suicides committed by men were reported in 2022. Depression is likely to be one of the contributing factors. On this episode of Healthcare Conversations with Nkele Matsoso, we are joined by Dr. Matsebula to learn more about depression in men. Dr. Matsebula is a psychiatrist in private practice. He specializes in trauma, anxiety, depression, and other mental illnesses. He is very passionate about providing education on mental health care, and that we appreciate. Dr. Matsebula, thank you very much for joining us.
Thank you so much. It's wonderful to be here with you.
Thank you. We're looking forward to learning from you. What are some of the key signs and symptoms of depression in men that healthcare professionals should look out for, particularly those that might differ from women?
Thank you. I think that's a very nice way to start this conversation off. So you get, just to break it down a bit more further, I know the colleagues probably know this, but you have different families or different groups of mental illnesses. Mm-hmm. You have some where the person experiences a break with reality. These are your psychotic disorders. Then you have another big family which are called mood disorders. And as we know, the word mood relates to how a person is feeling. And the word disorder basically means those feelings become uncontrollable. So depression, one of the mood disorders that we have. Before a person presents to a colleague with whichever symptoms, I think it's important for us to be aware that societal norms are going to influence how that person is going to present. So in this case, when we're speaking about men, in many instances, men are, I'll use the word hindered on purpose. They're hindered by certain societal norms. So instead of feeling sad or expressing sadness or expressing tearfulness, the man is most likely going to present to his healthcare practitioner with irritability, with increased frustration, with a short temper, with more anger. That's what we see there. And then when the practitioner starts asking them questions, then the other symptoms are going to come up, like lack of enjoyment of things that the man used to enjoy before. They will present with difficulties with sleep, changes in their appetite, changes in their weight. Another really significant one for men is going to be a change in their libido or their sex drive. So in many instances, the man is going to present with, "Doc, I noticed that I'm struggling in the bedroom." So changes in libido. We also start to see things like changes in their memory, changes in their concentration. And a particularly tricky one for men is they're going to present with suicide ideation. In other words, they're going to present with thoughts of death. Now, remember how I started off by saying that societal norms hinder men. Society says men should not talk too much, or men should not express weakness. And for many men, when they feel that they are no longer able to do the things that they do, they begin to feel that I'm feeling weak. And these thoughts of death as well are also linked to these feelings of weakness. So the healthcare practitioner needs to be quite deliberate in trying to tease out these symptoms. So the last really big one is the suicide, as I spoke about, that the men start to think about death. And we do know, and perhaps we'll speak about this as we proceed, we do know that the numbers of men that die by suicide, those are quite high.
Listening to you now, I'm thinking some of the symptoms that you mentioned, frustration, irritability, anger, suicidal thoughts, those are not the kind of things that would take a person to go and see a GP. Maybe lack of libido is one thing that might make a man to go and see a GP. But under normal circumstances, how then would a GP know when a man comes with flu, for example, that he also does have depression? Would they normally have to ask other questions? Because flu may not necessarily, fatigue might be part of it, but might not include anger, irritability, frustration, all of
Quite right. So what we advise our colleagues to do is when their patients come into their practice and they go to register with the receptionist, and then they also then maybe go to have their blood pressure done or their temperature done or their weight done, what we ask colleagues to consider is to print out little questionnaires, little 2-minute questionnaires, where the person is able to say that, oh yes, I'm still okay in terms of my mood, or maybe my partner has started saying that we notice that you're a bit more irritable these days, or maybe even colleagues, if the man is working, maybe they might have said that they noticed that he's a bit more irritable. So that's the first step, that there must be some form of questionnaire. Then the other thing that we ask colleagues to do is, yes, the person comes in, maybe they've come in with the flu, maybe they've come in with a red eye, maybe they've come in with tonsils. There must be a 1 or 2 minutes where the GP asks the man, so how are things? And that how are things does sound a bit vague, but the GP does know that he's trying to, or she's trying to tease out certain information. How are things going at home? How are things between you and the partner? How are things at work if the man is working?
Yes.
Are you sleeping okay? Are you eating okay? So small questions like those are going to leave certain really important hints for the GP to pick up on.
Yeah. Well, I guess if those questions are not asked, that is why there would be a lot of men who are not just men, probably everyone, who have depression, undiagnosed depression. But what are other societal or systemic barriers that contribute to depression being undiagnosed?
So I think when we're speaking about societal or systemic factors, there are many studies that have been run that have looked at this. And we can largely break them down into 2. The first is policies, either state policies or the country policy. And we do know that globally, there is this paucity of healthcare policies and campaigns that are directed towards men as a demographic. There's a journal called The Lancet, and that has spoken about how men are dying from preventable illnesses. Men are dying from non-communicable diseases at rates that are quite unnecessary. So the lack of these policies, the lack of these healthcare policies that are directed towards men, I think is a significant one. The other one that relates to society now, and we had touched on this in the previous question, there's something called restrictive emotionality. And those are just big words that say a man struggles to express himself because of societal norms. As we mentioned earlier, society says it's not acceptable for a man to say, I feel tired, or I feel sad, or I feel as if I'm unable to do X, Y, Z.
Men don't
There's
cry.
that. Men don't cry.
Expressions.
Quite right. Boys don't cry, or suck it up, or toughen up kind of thing. Or just go to the gym, or go drink, because that's also what
they do,
that's what gets said. So it's such societal norms that then are going to prevent a man from coming to see his GP. And we do know that as a demographic, men are less likely to come to their GP or their nurse practitioner for wellness clinic visits. These are just your basic checkups. Or in the early phases of illnesses, men are less likely to do that. We do know that men are more likely to present in the later stages of the illness. And in many instances, by then, you find that the curative aspect is going to be a bit more tricky. So it's those factors. And then the last and most important is how a man views himself, how a man thinks of masculinity, for an example.
Yes.
So for some men, to be masculine means to be able to tough it out. I'm feeling unwell, I'm going to tough it out. I'll go buy some Panados and I should be fine. Whereas we do know that's the last thing people should do. People should rather seek care with their clinicians.
Yeah. Sure. So how important then, from what you said, because there are obviously those societal norms that may cause a man not to even seek help, but once they've gone and consulted with a GP or with a psychiatrist, how important is tailoring treatment to accommodate these societal roles and pressures men are faced with?
Thank you. I think that's such an important question. The first step would be for the clinician to educate themselves. So yes, whether it's a nurse practitioner, whether it's a general practitioner, we do know that they go either through to nursing school or to medical school and they get taught these things. But we do advise that they continue learning, they continue updating their knowledge. And the reason this is so important is for two reasons. One, they will learn to identify certain atypical symptoms of depression that a man might present with. And we've touched on those, the irritability or the anger or the frustration. The other really significant benefit of improving one's knowledge is to become aware of one's own biases or a person's stigma, for an example. It is going to help with those. It is also going to help, especially in the workplace, for an example, where if we say we're going to provide some form of training, people are going to be aware that this is what depression looks like. This is how we need to address it. And then lastly, and equally importantly, especially for my GP colleagues, that is going to help because when this man is sitting in front of you, you are going to know that when we start speaking about depression, the conversation is going to terminate in medication. Yes. And different medications have got different side effects. So the men should know that this medication, there is a certain risk of a person's libido getting worse. That medication, there's a risk of the person maybe gaining weight. So that is how the GP is going to tailor that information to this man sitting in front of him or her.
This podcast is being sponsored by Origin South Africa, a member of Aurobindo Pharma Group, committed to a healthier life. Now back to our podcast.
I'm now imagining as a doctor, you have the man sitting next to you saying, with this medication, you run a risk of libido getting worse, or you run a risk of gaining weight. Women would be more concerned about gaining weight, I'm assuming, but other men would be. But I guess a man, you say you run a risk of libido getting worse. And the man says, in that case, I don't want the medication. What happens next?
So there, even before we go to speaking about medication, it is extremely important for either the GP or the nurse practitioner to establish what we call a therapeutic relationship. In other words, this office where the two are sitting should be a safe, comfortable space where the man can speak about things that concern him.
Yes.
Sometimes we can come up with other options. There are other medications that are less likely to cause issues with the man's libido. Sometimes you do find situations where, let's say the gentleman has become a widower, for argument's sake. Then there we know, and there's no romantic partner that the person has. Then there we can say, okay, there's no one in your life at the moment. Let's try this medication. If it does cause some form of erectile dysfunction or libido going down, come back and tell me about it. We can either adjust the dose or we can give you something else. The reason this is so important, the reason it is important to tell the man about other doses that are available or other treatment options that are available is it cements or makes concrete the therapeutic relationship. Yes. In other words, the man is going to feel that this person that I'm speaking to sees me. They don't just see a number in a queue.
That's so true. I was actually going to ask about what are the different treatment strategies or approaches. So I think perhaps you can add to what you just said, but perhaps there are some which are more effective in men than they are in women, or which are more applicable to men than they are in men. Is there something like that?
So when it comes to treatment, we ask our colleagues to do two things. And these two things are equally applicable and equally effective to both men and women. The first is medication, and we've touched on that. The second one is psychotherapy, seeing a psychologist, or talk therapy. And that is really important because medication is going to address the structural aspects of the brain. We do know that when a person develops depression, the brain physically changes, and the medication is going to help reverse that. The psychotherapy or the talk therapy, that speaks to how the brain works, or in other words, how the person thinks. So it is in sitting and talking with the counselor or the psychologist that the man's unhealthy thinking is going to be picked up, and it's going to be shown, it'll be shown to him that, look, maybe when you speak like this, it's not the healthiest way of thinking. Maybe we need to address that. So the psychologist will identify the healthy ways of thinking, point them out to the man, and then the psychologist or the counselor will help the man to develop new ways of thinking. Why is that so important? It is important because in many, many instances, the antidepressants are going to go away. In many instances, these are not going to be lifelong. What is going to be lifelong is the way the man thinks, the way he thinks about himself, the way he thinks about his environment, the way he thinks about the future. If we can get that thinking to be healthier, then we can improve this person's quality of life and, quite frankly, long-term prognosis as well, because this man will be able to lead a healthier life.
A healthier life. No, I think that's a positive thing in a sense that if a man can see that I'm not going to be on medication all the time, and if with depression, unlike the other mental illnesses, the fact that it's not that chronic, that it can get healed. Basically, that's what I'm hearing.
Yes, it can be treated. So, and I think I should have mentioned this in retrospect. When the man presents for the first time and they need antidepressants, all they need is about 6 to 9 months of taking that medication consistently. Then we know that they should be fine. Yes, in some instances, if the stressors are still there, or if there are certain things that have not been addressed, like the way he thinks, then the risk of relapse, that becomes real.
Yes.
If the man has been treated before and they completed the treatment, or maybe something went wrong, then you find that in some instances the treatment needs to go up to about 2 years' time. So in many instances, you find that the antidepressants will be started, we'll monitor how the person does, and then those antidepressants will go away. There are some instances where that treatment then does have to be lifelong. But this depression that we're speaking about doesn't fall in that family.
Okay, it's not necessarily. Okay. We spoke a little bit, we touched a little bit on cultural perceptions of masculinity in terms of how it influences men's mental health. How does it influence men going to ask for help in the first place? I know you did mention as well that, there's some hindrances, basically. How does the culture have an influence on depression in men in general?
So in some instances, culture can be viewed as a monster standing at the gate of the clinic. And when I say this, I'm not being dismissive of culture. That is not what I'm saying. I'll say it again. In some instances, culture can be viewed as a monster that stands at the gate and turns men away. How does it do that? It will say, you are a man. You're struggling to sleep. Maybe go buy more alcohol. You just need to relax and go to sleep. Sometimes it is going to say, you are a man. You are struggling in the bedroom with your libido. It is the woman, or it is your partner. They are taking something, or they have done something. Go find yourself another woman. Or the cultural belief is going to say, as a man, you must not be weak. You must not cry. You must not experience certain feelings. That is how, unfortunately, culture can prevent men from seeking help. But I think it is really important for either the general practitioner or the nurse practitioner or any healthcare professional to be able to ask around these questions in a sensitive way. The last thing that we want as psychiatrists is for a man to walk into whichever, either clinic or doctor's rooms and to feel attacked and to feel as if he is being made out to be less than. That's the last thing we want. So it's really important that the clinician knows how to ask around these things in a sensitive way. And it is also important for the clinician to be able to point to the man that maybe the way we view masculinity is not the healthiest. And the clinician can give the man a small example. A small example would be the man maybe is watching soccer or is watching rugby or any of these elite sports. And as we know, when, the team has lost or the athlete has not come first but has come third, they tend to break down and cry.
Yeah.
And the clinician can say to the man, but notice how we'll look at the athlete crying and we'll be fine. We'll be fine with it. We won't attribute any weakness to that person.
Yes.
Why can't we do that for maybe someone else who's not an athlete? Why can we not say, if you, as Dr. Matsebula, experience sadness and you cry, why can't you be allowed to do that?
Should be normal.
It should be normal. So we can use those things to assist the man.
Is there one key takeaway that you'd like to leave with our healthcare professionals about men and depression?
Thank you. I think it's a wonderful question. I know I've been saying that a lot. I think the take-home message is we'll have to use some stats for that. We do know that in South Africa, we've got the South African Depression and Anxiety Group, or SADAG, and they routinely release statistics. As of late 2023, I'm not sure about 2024, but as of late 2023, about 13,000 people died by suicide in the country, in South Africa. And men comprise a significant proportion of that number. Men, we're looking at about 11,000. So I think it's really, really, really important that we try to catch these men. It's really, really important. I think far too many men are dying from preventable pathologies. Far too many are passing away from potentially treatable pathologies, and depression is one of those. So I think it's really, really, really important that we learn to pick it up, the depression. And as I've mentioned, and I'll do it again to summarize, there can be some small questionnaire that a man can complete while he's waiting to go into the doctor's office or the nurse practitioner's office. And when they go in there, yes, they might have come with a strained ankle, but the practitioner must ask about other aspects. How are things there at home? How are things at work? How are things in the bedroom, for argument's sake? And let's not fear. Let's speak about these things. The help is available. The help is effective, and it must be given to these men who need it.
Who need it, yeah. For me, I must say the takeaway here is for the doctor, the healthcare professional, the GP, the nurse, to be able to pick up that the man is depressed, the man must have stepped into that practice in the first place for one reason or another, which could be a physical ailment. Now, what is also important is for us as the community to be able to pick up these things ourselves. As a wife, as a partner, a woman, mother, a child, you need to be able to pick up that my partner, my husband, my dad is depressed and therefore needs to go and see a healthcare professional. So I feel as much as we've come to the end of our conversation, we need to have another conversation where we'll focus the episode on talking now to household. How do you pick up that this person is depressed? So Dr. Matsebula, I would like to have you for another episode where you'll be talking to South Africans about how to pick up that their male counterparts, be it a colleague, father, or husband, needs to see a psychiatrist or a psychologist or a GP. Thank you very much for your time.
Thank you. I'd be happy to come back.
For listeners, if you found today's discussion enlightening, be sure to subscribe and join us for more as we continue exploring healthcare matters together, one conversation at a time. This was an interesting conversation. We're going to have a lot more of these conversations with people in the industry.